to talk about trabeculectomy troubles in few slides, but try just to make it a panoramic overview more than anything else. So, sorry, it's not working. Can I have some help with this one? Okay, I'll use the PC. So this is just one study to show that it was a kind of review for a consultant in the UK, and they reported almost 45% rate of complication, early complication after TRAP, and almost 40% rate of complication after TRAP at later stage. And a lot of patients, they had more than one complication. So in fact, it's quite common to have a lot of complications for any patient who are having the trabeculectomy surgery. So we'll just go through some tips to reduce this. We'll think from the first step: avoid high volume local while doing the trabeculectomy, especially for advanced cases, to reduce the chances of wipeout, and avoid massaging. Consider GA if you would like to reduce the risk of wipeout, but if you are considering GA, you have to ask the anesthetist to avoid low blood pressure during the GA and avoid avoid high CO2. So aim for low CO2 GA to reduce the risk of wipeout. And even if you are doing it under GA, you have to give local at the end to reduce the inflammation and the pain related cytokine production, which can lead to more scarring. The most, let's say, difficult situation in any patient having TRAP is either having hypotony or failure in the mind of the surgeon. So one big challenge, if you have a patient like this, they already have advanced glaucoma and that's their field of vision, and then they had the hypotony, and you end up with this. So in fact, you are causing harm by doing this, especially with the hypotony. So from my point of view, the way to reduce the risk of hypotony is to follow the Moorfield's safer surgery system. And this is a very simple system. What you need to make sure, your scleral flap should not go to the limbus, should be away from limbus 1 millimeter. Your sclerostomy should be tiny, not very small. Middle, in between, like dimension should be in the middle of the actual scleral bed. And you have to do wide dissection, as wide as possible, and apply your mitomycin away from your scleral flap, as again, posteriorly. And that will allow posterior flow. And make sure your sutures are tight. This is the kind of summary of the safer technique of Moorfield. So regarding the scleral flap, you have to be dynamic, not every time 3x4, not every time 70% thickness. If you have risk of hypotony in such cases, you have to go for like a wider flap and possibly less thickness. And the opposite, if you have hypermetropic patient, you can go for less scleral flap dimension and possibly even less thickness. So not very thick, because it will cause valving, it won't work. So regarding the scleral flap, we have obviously many options. Take sutures as much as it takes to make sure there will be no proper flow on the table, only oozing, minor oozing, no more than this. And even if that would meaning like making a lot of scleral sutures. So these come together usually: hypotony, shallow AC, and choroidal detachment. We may have a lot of issues. We all know about it. I'm not going to go into details because of the sake of the time. So in fact, if you have this kind of situation, then what you need to know is how to deal with it. If you have early hypotony, so you need to reduce the steroid and consider cycloplegics. You can always give intracameral Helon or consider revision. And that's depending on how dramatic is the situation. If you have late hypotony, we all know you have to consider revision, but you need to be prepared with the scleral graft if that's serious. In cases with uveitis, because you don't know whether this hypotony is happening because of ciliary body shutdown or overflow, if you are not sure, inject air. If you inject air and then see the patient within few hours, if you see the air under the conj, it means it's over draining. If you don't see the air, so possibly it's just ciliary body shutdown. This is just one situation where I did kind of without revision. It was hypotony. I did not choose to open the wound. I just chose to do compression suture. You have to go really deep and take the scleral bed and they take the compression suture, and that will sort out the hypotony. And the beauty is you can always remove these stitches early days, but then once it's about a week or two, it will be epithelialized completely and it will be embedded into the bleb. It won't cause any harm, but that's will be 10 minutes job rather than 1 hour job or half an hour depending on the situation. Now, the opposite is the actual scarring and inflammation. And if you have case like this, you know it's a bad prognosis. However, if you have cases like this, simply you can just remove the scar tissue from the edge, and that will give you good flow, especially if you combine this with the mitomycin or 5-FU injection. If I have something like this, for example, if I see it's flowing from one end, but it's not flowing on the other end, and even if the pressure is perfect, I wouldn't wait. I would always do gentle needling to reopen the flow on the other side, because this patient is at risk of having scarring. I wouldn't wait till it becomes obvious. So I would just do gentle scarring to open the scar tissue. And obviously we know all that we have to make a big tunnel to be able to avoid, sorry, it's just gone. Anyway, so you have to have big tunnel and do the needling. Dealing with hemorrhage is very important to reduce the risk of scarring, because bleed is the worst enemy actually. And pre-op phenylephrine and iopidine is very important in such cases to reduce the risk of injection. Initial cautery, do not wait till your pocket becomes full of blood. At the beginning, just do cautery step by step. Otherwise, you will end up with a pocket full of blood, and then the risk will be high after the surgery. Always do blunt dissection as well. Wound leak, we all know wound leak could be a nightmare. If this is tiny one, you can just either, if this is at the limbus, you can consider bandage contact lens depending on how bad, but then the best thing to do is to suture it. But if this is something like this, where it's leaking from all over with a very tiny cystic bleb, then you have to do revision, and you have to remove this kind of thin bleb and cover it with a healthy conj. This is very important. To avoid the wound leak, you have to make sure they are suturing very nicely. You have to avoid, you have to put your mitomycin away from the wound, and you have always to protect the edge of the conj. Do not immerse the edge of the conj with the mitomycin, and then you have to test it at the end with the fluorescein. Ptosis, again, we all know that ptosis, it can be mechanical because of the trauma, but there is another reason, which is obviously the cystic encapsulated bleb. If you see cystic encapsulated bleb, do not wait till it becomes a problem to the patient, and you can always needle it to reduce the risk of ptosis. And lastly, if you have a diaphasia where the patient is feeling the bleb all the time, then the best thing to do is always to do suturing. And as you can tell, take one bite here, another bite at the end, and then you link things together. Can I just have 30 seconds only? So you can just make it really tight, and that will just stick the whole thing together. And it will, after a few days or so, it will drain the area where it's leaking nicely, and it will keep the drain only on the area where the bleb is. And that could be the best thing to do in such cases. And that's it really. Thank you so much for your attention.